Hi, I'm Jack Cush, executive editor of RheumNow.com. I'm here at ACR 2017 in San Diego with my best friend and mentor, Dr. Ted Pincus. I want to tell you that I started out in 1984. Ted was one of the first big-time guys to engage me, and he was so kind then. He's been kind for like the last 35 years, and he's here to tell me about damage in rheumatoid arthritis. Over the years we have lots of discussions about what we're not doing right, what we should do better, and something that's come to your attention that you may come brought to my attention is this whole issue of damage. How did it first come up?
Well, thank you, Jack, and thanks for those kind words. The way it first came up was, as you know, in rheumatoid arthritis, we have 7 core data set measures. One of them is Physician Global on a 0 to 10 scale using a visual analog scale. And I noticed that sometimes I would have a patient who had no swollen joints and had a sedimentation rate that was perfectly normal, and yet I felt uncomfortable to say they have a Physician Global of 0 or even 1 when they had a pain score of 8 and they had deformed joints. Mm-hmm. So I thought, well, how am I going to account for this? And I decided what we have on our rheumetric scale, which I think I can show you here, sure, has the Physician Global, but also has 3 globals for inflammation, damage, mm-hmm, and distress, which is fibromyalgia and depression, which also impacts our patients, many of our patients, and can contribute to management issues.
So inflammation, damage, and distress is filled out by the physician?
This is by the physician. Right. It's not easy to get the physician to do any work. I don't have to tell you, Jack.
There's not a muffin or a dollar attached
right
to it? You know,
the only thing you can count on is clicking the billing statement.
Right.
And you'll notice that we have, instead of a 10-centimeter line, we have 21 circles, because we found that physicians, at least in the exam room who are rheumatologists, don't know how to use this advanced implement called a ruler. Oh. So, and it's actually easier, because then you don't have to worry about when you photocopy 10 centimeters, sometimes it becomes 9.8 or 10.2.
So where does this play? I mean, so you find that this explains some of the issue, and now you can kind of quantify it.
Well,
how should this be playing out?
Well, we are just beginning to do this, and we are still in the process of validating some of these concepts. But I can tell you, we have one poster here at the ACR meeting that says, in all of our diseases, which are thought to result from inflammation and which we think we treat only inflammation to control damage, that the scores for damage are higher than for inflammation. For example, in rheumatoid arthritis, it's about 3 versus 2.2. And in lupus, ankylosing spondylitis, psoriatic arthritis, gout, polymyalgia rheumatica, the scores for damage are higher than inflammation. I think what this suggests is we should be measuring in some way, quantitating damage and distress as well as inflammation. All of our measures traditionally are directed to inflammation, but that may not be enough to figure out what's going on with our patients.
So quantifying and identifying damage, you taught me a long time ago that HAC predicts damage. HAC predicts everything.
Yeah, absolutely. You
so
got it, Jack. You're a good student.
I was a young dog then.
Yeah.
And, you know, the tricks came easy.
Yeah.
But the question is this being picked up by HAC, or is this still something different than HAC?
It's picked up by HAC, but it's also picked up by DOS-28 and by CDI.
So it's buried in there.
Because Patient Global is part of all these indices, and a Patient Global of somebody with a lot of damage or a lot of fibromyalgia may be 6 or 7. And actually, Jack, that's one of the reasons you can't get into remission and even can't get an ACR 20 in a clinical trial, which is probably more important in why we only see 60% ACR 20s in clinical trials than the target is not correct.
And is this somewhat validated as well by the common practice observation that even though you've got a great drug, biologic, DMARD, you still need to use Tylenol or prednisone in low doses, or some non-steroidal or actual narcotic medicines to manage the patient?
That's true, except don't use narcotics.
Absolutely, I agree.
If you can help it, yeah. But that's right, that the patients, and we know that even in the best clinics in the world, using any index we have, that we see fewer than 30% of people in remission, sustained. And so that means there may be something about the measure that's picking up damage, even if the patient has no swollen joints in normal laboratory tests.
So this is the rest of the equation. I think what you're doing is you're putting a spotlight on it so people pay more attention to it, and hopefully it'll lead to paying not just attention to it, that it's there, but we got to do something about this.
Absolutely. And I will say also that using this scale, and actually the Rapid 3 scale, shows that osteoarthritis today is a more severe problem than rheumatoid arthritis in usual rheumatology care. When the patients come in, they're similar, but since we have such good treatments now for RA, the mean Rapid 3 score goes from 15 to 11 in RA over the next few months, and in OA it only goes from 15 to 13 and a half, and that becomes statistically significant and also clinically significant.
So now, as an old dog, I'm still learning new tricks from the master.
Well,
that's it for
thank you,
now.
Jack.